Yeah. So I request our next speaker, Dr. Vaishali Gupta, who is going to be talking on simplifying the management of ocular toxoplasmosis, interpretation of lab tests, and various clinical features of toxoplasmosis.
Hello. Good evening, and thank you, Chitra, for giving me a topic that will take 1 minute of my 6 minutes. It's a long topic. Anyways, talking about toxoplasmosis, it's caused by a protozoan which causes the Toxoplasma gondii. I'm just going to give very few practical tips. The first one is a congenital toxoscar. It's important to know about this scar because many times there are diagnoses like macular coloboma and so many other things are being made out of it. So if you see a scar with a scleral show right in the center, it's just a congenital toxoscar, nothing required. Just tell patient to review SOS because it could get symptoms anytime. Coming to toxo, which is active or inflammatory, you may have an active lesion sitting next to a congenital toxoscar. So that's what that's what you are afraid of. And these are called satellite lesion, typical white, small, with overlying vitritis. The acquired variety of toxo lesions, however, may not have a scar sitting next to them. So don't always look for the presence of the scar. Typical lesions of toxoplasmosis are retinitis with headline and fog appearance. Many times you may have cryolysis plaques, which are multiple small deposits on the surface of the retinal blood vessels that may be seen either close or even away from the primary lesion and are pointed towards the diagnosis. If it happens in an HIV patient, it may not be very typical. It may be very extensive, necrotic, and may resemble arm. Now, fluorescein angiography, to be very honest, doesn't show you much except that there is retinitis, the lesion which becomes progressively hyperfluorescent in the late phase. However, OCT actually has some of the very important biomarkers. And it's important to know these because I personally don't do fluorescein, I just do only OCT. So if you are seeing hyperreflective opal deposits on the surface of the retina, or you are seeing a posterior hyaloid which has hyperreflective round deposits along the posterior hyaloid, and especially if they are mirroring. So if you are seeing this mirror image deposits on the hyaloid along with the retina, some retrohyaloid hyperreflective dots, and the involvement of the choroid. This is very important. Toxo causes the involvement of retina. So you see retinitis, but there's always retinochoroiditis. So you will see involvement of the underlying choroid in toxo, unlike in sometimes diffuse lymphomas that might resemble this, or viral retinitis, which commonly resembles it. Viral retinitis will not have associated choroidal involvement. Investigations, none. Just clinical. Serology, no. Not definitive. Goldman-Whitmer coefficient, you could do if you want to, but by and large, not available. PCR is only for atypical cases. So what are the indications? You don't have to treat every lesion simply because it is there. There are indications for treatment. If you have these lesions in the posterior pole, near macula or optic disc, and the vision is 612 or less, or you feel the vision is going to be threatened, or you have large lesions, that is irrespective of location. I don't have to honestly talk about regimens because it's so much easier to go to the book and read about them. But typically they have been pyrimethamine, sulfadiazine, and folinic acid all combined together. There may be problems in finding folinic acid at times. So if you are not finding, please don't start this regimen. You could use alternative regimens like Clenda, Spira, Mycin, or other medicines. Very important tip is systemic steroids always start 48 to 72 hours after you have started antitoxotherapy and stop it before you stop antitoxotherapy. The total duration is 4 to 6 weeks, and I'm talking only of immunocompromised individuals. This is how the lesion would respond. On the left, you see vitritis, general haze, and a patch in the periphery. And this is following treatment with clindamycin with oral steroids that, of course, was added under the cover of clindamycin. This is that patient of cryolysis that I showed you in the beginning, and you monitor the response. You see the lesion going down and finally healing. Lot of talk about intravitreal therapy, Clinda and Dexa injection, and this is how the patient would respond. You can give a weekly injection. Nobody knows how many injections, but it is kind of a PRN kind of a treatment that you see the response and then inject if required. If from history, you know, it has been recurring time and again, it's time to give systemic prophylaxis, which is Septron actually every third day for 20 months, or treatment every other day for 1 year after you have given 45 days of active treatment for toxo. Why? This is my last slide. Why is it important to know? This is because this is a patient who presented like this. Somebody did not understand it was toxo. And I'm finishing. This is my last slide. And ended up with a situation like this, costing patient a complete visual loss. Thank you very much for your patient hearing. Dr. Chitra, you are muted.
I'm muted, madam. I think we can take some expert comments from Dr. Jyotirmay Biswas, sir. Excellent, madam. In 6 minutes, you did a fantastic job. Thank you.
So the toxo lesions, what I look for is the localized vitreous haze. If there's a diffuse vitreous haze, then you have to think for other entities like viral retinitis is a possibility. And as she has rightly pointed out that do not give intravitreal or posterior subtenon injection thinking that it is a posterior uveitis or pan uveitis, because that can be really devastating in such cases, lead to some kind of viral retinitis like picture. Reverse way also, you should not do that. You should not miss toxo as an ARN as a toxo lesion.
Thank you, doctor. Can you